Hello, welcome back. The beam now reached the detector. What will happen? How can we convert that beam into image? Welcome to RadSound FRCR Physics. We have discussed everything regarding the source, patient, signal optimization. This lecture is going to be about detector. Previous lecture was about scatter removal. Now detector. What happened? Previous lecture, we have optimized our primary transmitted remnant beam and minimized the scatter potent that may create the impact or the image quality, because as you can see the scatter is coming and has changed direction, so it is not carrying the exact information. If it reads the detector, that may lead to fogging or fog on the image, and that will lead to decrease quality of the image for diagnostic value. So the detector records the remnant beam and know the exact anatomy directly. To understand detector, we must go back a little. So historically, interference screen converted X-ray into visible light, then exposed silver halide film, chemical processing, which will form contrast once processed to display as contrast peaks. So, but in modern part, we're using computerized and digitalized radiography. So this is which is far better than the prior method, and it will produce a better image with a better quality, better diagnostic quality. So what reaches the receptor? We have primary transmitted photon, we have scattered photon, and also at the same time we will have absorbed photon. So which one reach the receptor? Which one was recorded as a positional image, or will take the information from the exposed size to the detector? Only the primary transmitted will reach the detector, but sometimes the scatter, especially the forward scatter, wasn't removed despite the filtration, despite all the maneuver that the protein underwent before reaching the patient, such as collimation, filtration at the patient level, such as compression, proper positioning, then post-patient after the patient, such as using grid, using air gap, and also geometric maneuvering. If still the scatter reached the detector, at that station, only the primary photon carries the useful spatial information. The scatter will add unwanted signal and it will decrease the contrast. It degrades the image quality. And to mention, it's also important, absorbed photon do not reach the detector at all, contribute only those to the patient and attenuation. So we will have our latent image form. That latent image will represent the photon, the transmitter photon, depending or based on the level of attenuation. Areas with the high attenuation, with the low attenuation, such as air in the lung, would have almost would allow 85% or most of the photon will pass to reach the detector. When it comes to soft tissue, around 50-65% up to the level of iodine that will absorb most of the photon, and only minimal amount reach the detector. So these spatial differences in the image attenuation or the object attenuation will give the structure of the image. As I mentioned, historically the film screen uses intensification screen and film. So film and screen, then the film had to be chemically processed, and it had a narrow exposure latitude. That era is now behind us. In the modern era, what are we using? Mostly we're using digital CR computerized and DR digital radiography. So in the CR, what's the most important? We use a photostimulable phosphor plate, cassette-based system, separate CR readout. This kind of use red laser to read the plate or the cassette. Then the same cassette will undergo through erasure to erase the latent image, okay, so that we can prevent artifact formation, and it has better, wider dynamic range than the print screen. So CR is a cassette-based digital radiography. We have DR. So what's the DR doing? In the DR, it is the main film. It is using flat panel detector, immediate electron readout. It has two types: direct or indirect conversion. With direct, just converting the X-ray into electrical charges, whereas the indirect must convert it into light, from X-ray, from photon to light, even possible, then from light to charge. So the PIM screens expose film, and the CR mostly stores energy, then exposed to laser for radiant, then light, white light for eraser, and whereas the the digital radiography mostly reads electronic signals. So remember, the CR is digital, but it's not same as the flat panel DR. Let's talk about the CR. So in the CR, mostly the PIM has many parts. It has protected the cassette. It has a protected layer. Then it has photostimulable phosphor, which is mostly made from barium fluorohalide doped to the europium, divalent europium. So that barium fluorohalide, sometimes bromide, sometimes can be iodide, will lead to formation of a latent image. So how the latent image is formed? So we get our X-ray put in interphosphor plate. So the X-ray come in the interphosphor plate. Then the energy excited electron. Then that excited electron become trapped in metastable state. So that trapped electron distribution will lead to formation of latent image. That latent image need to be read by a red laser so that we can have our main image. So how the process happens, we have our cassette, we have the protective layer, we have the phosphor layer, which contain barium fluorohalide doped in divalent europium, which mostly can be bromide, barium bromide, or barium fluorobromide, barium fluoroiodide. So then the X-ray excites electrons, so it moves from valence band toward the conduction band to stay in metastable stage. That stage will lead to formation of latent image. This is the latent image. So the latent image contains special pattern of trapped electron that must get exposed to red laser. Then the trapped electron will get released in a blue-violet photostimulable luminescence. Then the light. So in the end, electron within the plate after passing getting exposed to red laser will be converted into blue violet, or light will be released in blue violet color. Okay, then that light will be collected by photo multiplier tube, and the photo multiplier tube will convert them into electrical signal. The electrical signal will be digitized. So this is our image. Now we have the image. In the CR, with that image, after creating our main image, the plate must get exposed with into bright light. So to get to erase all the remnant of the latent image for use. If something happens, that will lead to artifact formation. So what are the common limitations of the CR? That if say we get image and there is programs that can be laser spot size, okay, that depends. The solution depends on the laser spot size. The sampling pitch, the phosphor thickness. If the phosphor is very thicker, that will be blurry. A thin phosphor might be better resolution. Light spread might lead to a reflection, which will lead to decrease spatial resolution, and some other artifacts such as ghost image because of reader line artifact, Murray pattern, like wavy line across the image, and the others. So these are the defects or artifacts that might happen while using computerized radiography. Because regarding the digital radiography, digital radiography uses flat panel detectors. The indirect system of digital radiography convert X-ray fast light via scintillator. Before then, light charge, then charge will be converted into data. Of the indirect flat panel detector is as follows. So we have protective cover, we have scintillator, which is mostly cesium iodide or gadolinium all disulfide. The important that cesium iodide mostly is formed like a needle-like crystal, so which will channel light toward the photodiodes. So then from photodiode TFT, that's TFT will convert them into signal. Then the signal will take to the readout electronics. Whereas the gadolinium of the sulfide is a phosphor with a more lateral light diffusion, which can reduce spatial resolution compared to the structured cesium iodide. This is a conversion X-ray. The X-ray heat scintillator, which will be convert the X-ray into light. The light will be converted by photodiode into charge. And the TFT readout to convert it into digital image. So now the structure. What are the main structure of the cesium iodide? As I mentioned, the cesium iodide is mostly needle-like, something like this. Okay, needle-like structure, channeling the light toward the photodiode. Then the photodiode convert that light into into charges, and the charges will be taken by TFT to read out to form the image. So whereas the gadolinium oxide is a powder phosphor and more lateral light spread, and it has a bit less spatial resolution compared to the structured cesium iodide. This is very important in exam because they will ask in exam bring question, and that may indirectly point that cesium iodide is the best, is has the better spatial resolution than the gadolinium oxide. Compared to the indirect DR, the direct DR, there is no scintillator. So meaning a light conversion from X-ray light may reduce spatial resolution in the indirect. So now the direct conversion of the X-ray into charge. And this at a high voltage electrode. So we have amorphous X-ray comes, then amorphous selenium will convert that X-ray into charge directly without intervening light conversion. So at the X-ray comes enters the amorphous selenium. The amorphous selenium will form kind of electron hole pairs will be created inside the amorphous selenium layer. Then the field pool charges, those charges will be taken by the TFT to read as a charge, and then to the conversion of the digital image. So because of the lack of light separate in the direct, it has better spatial resolution, no intermediate light stage, less lateral spread, potentially high spatial resolution, direct charge collection, so the no intervening light, limitation of the DR, charge trapping effect, sometime lagging or gust possibility, high voltage bias, okay, sometimes detector saturation. Let's compare the direct to indirect conversion. So first, X-ray will convert light in the indirect, whereas in the direct, X-ray will convert charge. So mostly scintillators are needed for the indirect. There's no scintillator in the direct, so it is directly out for selenium. This is why you cesium iodide or gadolinium oxide. So intermediate light stage is present in the indirect. There's no light stage in the direct. So main blurring might happen due to light spread in scintillator. There's no blurring, but still it is using electronics, so no blurring. So it's better spatial resolution in the DR, in the direct form of DR. The main strains, the readout TFT array, TFT, both of them are using TFT. So main strains, the indirect has high absorption efficiency, whereas the direct DR has high intrinsic spatial resolution because there is no light separate. For limitation, the indirect light spreads can reduce the sharpness. For the direct, the high voltage layer, millet lagging, charge trapping, ghosting, and others. So these are the main differences. So from direct, as comes direct, the X-ray will convert it to charged data. On the indirect, the X-ray will convert the fast light via scintillator, which is gadolinium oxide or cesium iodide. The charge will be then converted by TFT to data, and the image will be formed. So there are the differences between the direct and indirect DR conversion. Differences comparing the CR. We say detector is a detector system that is being used in the CR is cassette, imaging plate, IP, whereas the DR is a flat panel detector. The signal storage trapped electrons in CR and electronic charge in DR. Readout is red laser is used in CR, which is separately from the cassette. So you take the cassette, go to the laser, and then read the image. While in DR it's immediate and electronic. The charge will be converted to image. Workflow slower cassette transfer, then faster in the others, and on the other hand, dose efficiency generally dose will be lower in CR because of many factors that we're gonna discuss later. But a big dose is higher in DR. Artifacts, there will be scratch artifacts and others, maybe sometimes in DR, the date, pixel, lag, ghosting, dynamic range, wide dynamic range, both of them exposure, but the workflow is slower in CR compared to the DR. Let me just mention something which is important regarding the indirect DR, the indirect DR. So in indirect DR, we're using the scintillator, which is cesium iodide, okay, doped with thallium, okay. It's just important to differentiate it from the cesium iodide doped in the sodium or doped to the sodium. That cesium iodide doped to the sodium, we use it in the gamma camera. Whereas the cesium iodide doped to the thallium, we use it as a needle light structure in the indirect direct conversion. Finally, digital imaging has wide dynamic range. This is powerful, but it can hide overexposure. The raw data being signal passes through histogram analysis, lookup table, the image processing, and then DICOM up to the DICOM level. Hide overexposure. So we have to use something. So we are using exposure index. Exposure index reflects how much radiation reaches the detector. It's not same as the patient does. So we develop something. So let us take the deviation from the index. If the index is equals 0, it means the exposure is perfect. That is correct exposure to the detector. If the index is positive, it means there is overexposure. And when this becomes negative, that means the exposure is the image or the detector is underexposed. This can help us to decrease and minimize overexposure while maintaining the quality of the image. Remember this trap, processing cannot recover information that was never captured, meaning that underexposed image, we cannot recover a detail because we didn't even expose the object to the radiation, the proper dose that will give the quality image. So we cannot process anything to get the quality image post exposure. Let us recap. So remnant image reach detector, converting the signal and the image, then we have our detector type. So CR, which stores image in latent image in PSP, then read by laser, and then erase with using white light, and the cassette is cassette based. We have direct conversion, which can divide it into indirect and direct. Indirect must convert the X-ray fast into light using scintillators. Scintillators commonly use cesium iodide doped in thallium or gadolinium sulfide. The difference is the cesium iodide is very has the high because it is just is channeling the X-ray toward the photodiode because it just the structure is needle-like structure, whereas the gadolinium sulfide is powder. So all of them through flat funnel. So we have direct conversion whereby the X-ray is being converted into charge via amorphous selenium. Then we have safety monitoring to have a good safety to monitor the exposure via exposure index. So this marks the end of this lecture, and the next one is going to be making the image of diagnostic, because the factors affecting the quality of the image that we have already formed from via the detector. So we will talk about the contrast, resolution, noise, and sharpness, as well as distortion and artifacts. See you in the next video. Thank you for watching.